what I'm going to do is present you with these images. I'll give you a few seconds to analyze the images and collect the thoughts in your head and come up with a diagnosis in your head. So ultrasound images of this 50-year-old. Have a look at what is showing. I'll tell you that this is, let me just bring the pointer. So this is the bone, the left hemimandible, and this is the muscle over it. So just review these images, see what you think. And fortunately, we've got the image of the patient to go by and correlate it. So we can't really say correlated clinically. Okay, so what we are seeing here is this is the bone, this is the buccinator muscle. There's quite edema of the buccinator muscle. And if you look at the fat superficial to it, it's quite echogenic, which gives us a clue that there is some sort of inflammatory process going on. But what's the pertinent finding here is this hypoechoic collection, which is seen between the mandible and the buccinator muscle. And this is quite vascular, especially there's peripheral vascularity. So this patient went on to have a CT, contrast CT, and just have a look at these images. So what we are seeing here, in fact, CT confirms the findings that were shown on the ultrasound. There's this rim-enhancing collection here outside the left hemimandible and underneath the left buccinator, which is quite edematous, and there's induration of the surrounding fat. This is the coronal sequence again showing this small collection here. And the third image shows inflammatory process and enlargement of the 1B lymph nodes. And when we go on the bony windows, so here now we know that some sort of abscess is going on. We want to know what the cause is. So the bony windows show this curvilinear lucency at the apex of 38. So I'm sure you all got the diagnosis correct. This is the case of odontogenic abscess. So odontogenic abscess, it all starts with the caries of the crown, and that's why it's really important to brush your teeth twice a day and floss your teeth. I'm not a dentist, but let's follow the sayings of the dentist for this presentation. So it all starts with the caries of the crown. Then the infection travels along the root canal, goes down into the apex. And if the infection is limited to the periodontal ligament, it will lead to apical periodontitis. However, if the infection becomes organized, it will lead to collection of pus, and that's when it's called as periapical abscess. And when the periapical abscess erodes through the bone, this is when it's called as odontogenic abscess. Now, if the maxillary tooth is involved, which we see here in a schematic, and the infection goes up into the sinus, into the tantrum, then that becomes odontogenic sinusitis. If the mandible tooth is involved, the relationship of the sling is the one that separates the sublingual space above with the submandibular space. So if the root apices of the second and the thumb, and then that's when a patient can get in, this can lead to sublingual abscess. More commonly, it is the submandibular abscess that we see. This is the next case. 16-year-old with pain in the throat and low-grade fever. So I'll give you some time to look at these images. Contrast CT of a 16-year-old with pain in the throat and low-grade fever. So what we're seeing here is edema and enlargement of the palatine tonsils. In fact, in the second image, we see a small phlegmon at the anterior aspect of the enlarged left palatine tonsil. And there's also enlarged level 2 lymphadenopathy. So this is a case of acute tonsillitis. I'm sure everybody got it, right? So I've got a companion case here. 40-year-old with sore throat and fever. So what we see here is a rim-enhancing collection within the left palatine fossa. This is multiloculated and is heading towards the retropharyngeal space. So this is a case of peritonsillar abscess with retropharyngeal extension. So we know that tonsillitis is the most common deep space infection occurring in children and adolescent, and most common pathogen is beta hemolytic streptococcus. It can also be caused by Staphylococcus aureus, pneumococcus, and Haemophilus influenzae. So tonsillitis is different from peritonsillar abscess, and it's really important to make to differentiate the two conditions. Tonsillitis is just the cellulitis of the tonsils, and what we see on imaging is the tonsillar enlargement, and this typically is striated appearance of the enlarged tonsils and the posterior pharyngeal tissues. It is typically treated with antibiotics. A peritonsillar abscess is the infection that has penetrated the fibrous tonsillar capsule. So we see a rim enhancing collection just like any other abscess, and it can spread to the surrounding spaces like parapharyngeal space and the retropharyngeal space, as we saw in our case. So central necrosis and rim-lying enhancement of the peritonsillar abscess is seen, and the different because this is usually case and high fever. Let's see what you can appreciate. So what we're seeing here is edema and increased mucosal enhancement of the epiglottis, the array epiglottic fold. In fact, the epiglottis has a thumb-shaped morphology. There's also narrowing of the airways, and there's a rim-like enhancement, a rim-like collection in the right parapharyngeal space. So indeed, this is a case of supraglottitis, which is another name for epiglottitis. So epiglottitis is usually reserved for, most commonly it is called by H. influenzae. Following the advent of H. influenza vaccine in children, it is rather less prevalent in children now and more sort of prevalent in adults. And it's a life-threatening condition, especially in children, but rather indolent in adults. And why is it so? Because in adults, they can tolerate the supraglottic edema a bit better compared to the children, which have those have small space is small. That's why they can't tolerate it, and it can lead to life-threatening condition. Complication can be necrotizing epiglottitis and neck abscess. This next case is acute onset of dyspnea after ACE inhibitors. So I'm sure everybody can appreciate this narrowing of the airway and this edema enlargement of the soft tissue of the oropharynx. This patient went on to have instant intubation to secure the airway. So this is a case of angioedema. And the cause for this condition is usually allergic or hypersensitivity reaction. Hereditary disorders such as C1 esterase inhibitor deficiency or ACE inhibitor. This condition needs emergent management to secure the airways. My next case is 40-year-old male with painful swallowing. Okay, so what we're seeing here is hyperdensity within the sublingual space towards the left, which is in keeping with the calculus, and there's associated enlargement of the submandibular duct, upstream dilatation of the submandibular duct, which is here seen here with the yellow arrow. There's also edema and induration of the left submandibular gland and enlargement of the level 1 A and B lymph nodes. So the diagnosis here is submandibular duct calculi with sialadenitis. So what is sialadenitis? It is the inflammation of the salivary glands. Most commonly, the submandibular gland is involved, but you can also see this with the parotid glands. Most common cause is the bacterial infection, such as Staphylococcus or Streptococcus, other organisms. And so viral infection is also possible, especially with the parotid glands. And if there's bilateral involvement of the parotid glands, this condition is called as mumps. The other causes could be dehydration, immunosuppression, and iatrogenic causes. Typically, this condition is unilateral, and we see the involved gland is enlarged and enhances. There's ductal dilatation secondary to the obstructive calculus or stenosis. We can see surrounding cellulitis and myositis. And more commonly, the submandibular duct is involved because it has the relatively larger diameter compared to the parotid duct. It has an ascending course, and also its secretions are more mucinous and more alkaline, so they are more prone to stasis. All right, so we've covered some of the common acute conditions of oropharynx and salivary glands. We move on to the temporal bone now, involving the ears. 20-year-old boy with right otalgia and fever. I'll give you a few seconds to go through the images. Okay, so what we're seeing here is opacification of the right mastoid hair cells. There is dehiscence of the mastoid septations here. All these septations which we usually see are not there. There's also dehiscence of the sigmoid plate. So this patient went on to have contrast MRI and MRV, and we can see the pus within the mastoid hair cells with rim enhancement, central necrosis rim enhancement, but it's interesting to see that there is an epidural abscess as well. And in fact, if we go to the next image, there is a filling defect within the right sigmoid sinus extending into the IJV. So there is thrombosis of the distal transverse sinus, which we're seeing here nicely on the MIPS of MRV. And there's also thrombosis of the sigmoid sinus and IJV. So this is a case of diagnosis here would be coalescent mastoiditis. So coalescent mastoiditis is essentially a complicated mastoiditis in which there is destruction of the mastoid trabeculae and the infection spreads. So infection can spread through the inner cortex or the outer cortex, and this will then this condition is called as coalescent mastoiditis. So if the destruction is through the outer cortex of the mastoid, we usually see a subperiosteal abscess. And the abscess at the mastoid tip can go into the surrounding soft tissue, which has an eponymous name called as Bezold's abscess. If the infection spreads anteriorly through the temporal bone, it can lead to petrous epiccitis. If there is extension intracranially, which we nicely saw in our case, it can lead to epidural abscess, meningitis, cerebellar abscess, cerebral abscess if the infection spreads further up, and it can lead to dural venous sinus thrombosis. Next case is quite interesting. 70-year-old with acute onset vertigo and reduced hearing. So take some time to look at the images. I would say symmetry is our friend here, especially head and neck cases. Symmetry is always our friend. So make use of that friendship to come up to a diagnosis. So we have high resolution T2 weighted imaging of the posterior fossa through the IAMs in the first panel, and the second panel is a contrast T1 sequence. Okay, so what we're seeing here is reduced T2 signal of the membranous labyrinth. So if you look at the right side, which is the normal side, the normal high T2 signal of the cochlea is absent here, and it's replaced by the T2 signal. On the second image, there's T2 signal, reduced T2 signal within the semicircular canal. So this is the posterior semicircular canal. This is the normal one on the right side, and this is the abnormal one on the left side, where the normal high T2 signal is replaced by the low T2 signal. And on the third one, there is relatively low signal within the vestibule as well. And on the contrast scan, we are seeing enhancement of these structures. So this is a case of labyrinthitis. So what is labyrinthitis? It is the inflammation of the membranous labyrinth. And membranous labyrinth structures are cochlea, semicircular canal, and vestibule. Most commonly, these are caused by infections, which could be viral or bacterial. In fact, in our case, this was a viral infection in this patient. The other causes could be autoimmune, post-traumatic, tympanogenic as a complication of acute otomastoiditis. So, for example, the case of coalescent mastoiditis that I showed you can have further complication with a labyrinthine fistula and can lead to labyrinthitis. So these patients can present with acute onset vertigo, nausea, vomiting, tinnitus, and hearing loss, which would be sensorineural hearing loss. And on imaging, the normal T2 hyperintense signal is replaced by the hypointense signal. And on FLAIR imaging, they will have high signal, and on the post-contrast T1 weighted imaging, they will show enhancement. An important differential, especially in an acute situation, acute presentation, is labyrinthine hemorrhage. So how do we differentiate? So we've got two panels here. In the first column, we have pre-contrast T1, and on the second one, we have FLAIR sequences. So if you look at the second column, we're seeing high signal within the right side, so basal 10 of the cochlea, and in the vestibule here. Similarly, with high signal within the labyrinthine structures here on the FLAIR sequence. So this could either be a case of labyrinthitis or labyrinthine hemorrhage. So the way to differentiate is we go on the pre-contrast T1, and here we're seeing that there's high signal on the pre-contrast T1. So this is a case of hemorrhage. So this is a labyrinthine hemorrhage case. Whereas the top one is there's no high signal on the T1. So this is a case of labyrinthitis in the acute presentation. So that's it for the temporal bones. We will now go on to present some of the common condition of the paranasal sinuses. 20-year-old with reduced GCS. I'll give you some time to look at these images. So what we're seeing here is mucosal thickening within the frontal air cells. There are air fluid levels here. There's also a tiny collection within the superior frontal soft tissue, just adjacent to that frontal bone. And on the sagittal sequence of the reconstructed bony sequences, we are seeing some epidural air. And on the contrast MRI, there is a small epidural abscess. So diagnosis here is, yes, this is a complication of frontal sinusitis. The eponymous name is Pott's puffy tumor. So this condition is a complication of frontal sinusitis, wherein we see subperiosteal abscess and osteomyelitis of the frontal bone. Complications, as we saw in our case, can be epidural empyema. They can have subdural empyema. They can be meningitis, cerebritis, cerebral abscess, dural venous sinus thrombosis. The infection can spread to the adjacent soft tissues and adjacent organs, for example, into the orbits, wherein we can see preseptal or orbital cellulitis, and I'll show you some cases of these conditions further in. So always perform MRI and MRV to delineate the extent of the complication, especially if you're worried about dural venous sinus thrombosis. Next case is a 70-year-old with diabetes, and he has presented with nasal discharge. So we got 3 FLAIR axial images where we can see there's high signal within the paranasal sinuses, sort of florid high signal in keeping with mucosal disease. But there's signal void here within the right ethmoidal air cell and the sphenoidal cells. So thoughts, anybody? It's not going to be a simple case of sinusitis. So this patient proceeded to have contrast MRI, and just take a few seconds to look at these. So yeah, I think we got it correct. So what we have here is, moving this up, there's a black turbinate sign, which most of you could very nicely appreciate. So black turbinate sign, which means there is central necrosis, a lack of enhancement of the sinus mucosa because of necrosis, and there's rim enhancement. There's also soft tissue enhancement of the nasal mucosa, But the other important findings are the obliteration of the retroentral fat, and there's enhancement in the retroentral fat. So bilateral pterygopalatine involvement. There's edema of the basis sphenoid, and there's probably reactive edema of the basis sphenoid. And there's also orbital involvement here, and infiltration of the fat in the orbits. So this is a case of acute invasive fungal sinusitis. This is the most aggressive form of fungal sinusitis, most commonly caused by mucormycosis and aspergillus, and in fact we saw lots of similar cases during COVID times. It commonly occurs in immunocompromised patients, including diabetes, and carries a significant morbidity and mortality. Presentation is often very dramatic and has to be treated aggressively. So what are the findings on imaging? The nasal cavity soft tissue thickening, erosion of the nasal mucosa, and nasal emphysema are some of the earliest CT findings. So look at the nasal mucosa very carefully. The other pertinent findings are obliteration of the periantral fat. So the premaxillary fat pad and the retroentral fat pad. Look at these areas very carefully. They may have intraorbital extension, extraocular muscle involvement, and of course, intracranial extension can be in the form of cavernous sinus thrombosis. And I'll show you a case of cavernous sinus thrombosis in a bit. They can have vascular invasion in the form of carotid stenosis, pseudoaneurysm, infarcts and hemorrhage, and they can have leptomeningeal enhancement, cerebritis, cerebral abscess, and so on. So in a paper which I've quoted here, they showed that if more than two of these variables of these areas are involved, then that carries a high sensitivity, in fact 100% specificity and 100% positive predictive value for the diagnosis of invasive fungal sinusitis. So very important to be able to recognize this condition, and something that shouldn't be missed. I've got a companion case here, 62-year-old with eye pain and periorbital swelling following bone marrow transplant. So we can see mucosal thickening within the left maxillary antrum. In fact, the mucosal thickening isn't profound here. The right maxillary antrum is fine. There's just a small air fluid level here and some mucosal thickening at the anterior aspect. But if we look carefully, there is obliteration of this retroentral fat compared with the normal one on the right side. There's also soft tissue induration of the premaxillary fat. And on the coronal sequence, we can nicely see that there's orbital involvement, which is then confirmed on the contrast MRI. But what the MRI is adding is the leptomeningeal enhancement of the brain, so frontal lobe is involved. Now, this case is interesting, 50-year-old with nasal stuffiness and rapidly reducing GCS. And we presented a case series of this condition to the American Society of Head and Neck Radiology. So I'll give you some time to look at these images. There's a lot of findings, so take your time. And one of my registrars presented this case, so I'll let her speak after this. Remember, it's not only important to get to the diagnosis, but also to look at the complication and be able to communicate to the clinicians in a clear format what are the complications and what are the potential complications that this patient can land into if not managed on time. So I'll give you some more time. Okay, I'll let the
another case, common presentation, again with headache and nasal stuffiness. So here you can see we have ethmoid and sphenoid sinusitis, as well as, again, bilateral filling defects within the cavernous sinus. We also see some right orbital inflammatory tissue and right proptosis, and that pre- and post-septal phlegmon. We also see some leptomeningeal enhancement and some pachymeningeal enhancement within that anterior cranial fossa. And additionally, we actually have an extraaxial empyema within that posterior cranial fossa. Here you can also see that the filling defect in the right cavernous sinus is contiguous with that superficial petrosal sinus and extends into the transverse sinus as well.
All right. So I'm sure everybody can appreciate those findings. So sinusitis of the posterior ethmoidal air cell and the sphenoidal air cell. And if we look carefully at the cavernous sinus, we can see these tiny filling defects with rim-like enhancement. This is a case of cavernous sinus thrombosis. And then we don't end there. We have to look for the complications. So complication, if we go posteriorly, there's a epidural empyema within the posterior fossa. There's also infection spread posteriorly through the superior petrosal sinus into the sigmoid sinus. Here we can see this empyema again. There's also leptomeningeal, subtle leptomeningeal enhancement here, which is not nicely shown, but maybe the projection is not right. Then anteriorly, there's lots of soft tissue within the orbit. There is preseptal, postseptal cellulitis. There's also thrombophlebitis of this right superior ophthalmic vein. So heaps of findings here. Cavernous sinus thrombosis, usually the spread is from, it is a continuous spread from the surrounding soft tissues. For example, sinusitis, as in our case, facial cellulitis, trauma. And how do we make the diagnosis? So on a non-contrast CT, which is most of the cases, it is the initial modality. So we see hyperdense thrombus on the non-contrast CT, and I must admit it's very hard to make that diagnosis on the non-contrast CT alone. So we have to do a contrast scan, and contrast MRI is the preferred modality of choice. So distended lateral walls of the cavernous sinus with filling defects is the finding that we see on the contrast scan. Then the other supportive findings are distended superior ophthalmic vein, proptosis, narrowing of the ICA can occur, of course, because the cavernous ICA is just sitting there, so it's very likely that they'll get narrowed. And then you look for the complication like dural enhancement, dural venous sinus thrombosis, meningitis, abscess, stroke, carotid cavernous fistula. Okay. So then next we are moving on to the orbits. And with the orbits, I'm showing two cases here. The right one had right eye pain, and the patient on the left had left eye pain, incidentally. So take a few moments to go through the images. So yes, we'll start with the case on the right side. So remember, this is a case of orbit. So we have to look for the orbital complications. So there's this soft tissue swelling here in the preseptal region, and there's also some soft tissue within the orbitonasal groove. So this is a case of preseptal cellulitis. This one, whereas on the other hand, we see extensive ethmoid sinusitis, which there is sinusitis in this case as well, but it hasn't spread into the orbit. Whereas in this case, there is ethmoid sinusitis and subperiosteal abscess, which most of the people have correctly identified. But there's also infiltration of the fat within the orbit. So there is a post-septal involvement as well. So therefore, this is a case of orbital cellulitis. So this is a case of preseptal cellulitis, which is periorbital cellulitis, and this is a case of orbital cellulitis, and with all the complications from the sinusitis. Now, what is the orbital septum? Orbital septum is a fibrous sheet that extends from the periosteum of the orbit here, and then it extends medially into the tarsal plate of the eyelids. So this is the orbital septum. And what it means for us as radiologists is this imaginary line that extends from the periosteum of the orbit going through into the eyelid here. And this is the one that separates the superficial tissue and the deep tissue in the orbit. So it prevents the infection from spreading deep into the orbit. And the management, of course, is different. So it's very important to be able to correctly identify the two conditions. So remember, preseptal cellulitis and orbital cellulitis. So periorbital cellulitis and orbital cellulitis. Next case, 30-year-old with left orbital swelling and mucopurulent eye discharge. Yes, so this is, we can see that there is this rim enhancing collection at the medial canthus associated with preseptal soft tissue thickening, so periorbital cellulitis, and this medial canthus rim enhancing collection. This is an infected dacrocystocele or dacrocystitis. Sorry. So when there's dilatation of the lacrimal sac as a result of distal obstruction within the lacrimal drainage apparatus, this term is then called as dacrocystocele. And when there is superimposed infection and inflammation of a dilated lacrimal sac, that is then called as dacrocystitis. And so what we see, we see a dilated medial canthus mass. Clinically, we see a dilated medial canthus mass, and usually it's a clinical diagnosis. Patient present with pain, erythema, and mucopurulent discharge. And on CT, we can nicely see a cystic mass centered at the medial canthus. And then always look for the complications, so preseptal cellulitis, orbital cellulitis, and if the infection is deep, it can go further down into the orbital apex and can go into the cavernous sinus as well, and then can cause intracranial complications. Next case, it's rather a companion case, a 30-year-old with right eye swelling. So here again, we are seeing the preseptal cellulitis, but the other abnormality is not on the medial side, it's on the lateral aspect. So what is this? Can't be dermoid, we're talking about the acute emergent conditions of the head and neck. And the attenuation is not that of dermoid. Or inflamed dermoid, okay. So this is the expected location of the lacrimal gland, right? So this is a case of dacroadenitis. See, with this, all this enhancement and preseptal soft tissue thickening, it has to be a superimposed infection. So this is the enlarged lacrimal gland with preseptal cellulitis. Most commonly, this occurs as a result of infection or inflammation. Other differentials will be IgG4, sarcoidosis, granulomatous with polyangiitis, which used to be called as vagus, or there can be idiopathic orbital inflammation. But often there are cues as well in the history. So the last space is retropharyngeal space. We've got montage of images, CT as well as MRI, in a 40-year-old who presented with sore throat and fever. Okay, so yes, got it right, retropharyngeal abscess. So what we're seeing here is the rim enhancing collection within the retropharyngeal space here. So I'm sure everybody can appreciate this effusion within the retropharyngeal space, and on the contrast scan, there is this enhancement that we can also appreciate on the contrast MRI. So this infection has now spread to so again, we're talking about the complications here. So they spread into the right parapharyngeal space, and we can nicely see that the left side parapharyngeal fat pad is preserved, whereas on the right side, the fat pad is obliterated, rather anteriorly faced. There's also spread into around the right carotid sheath. And then we did the MRI on this case, and we can see this loculated collection within the retropharyngeal space, but there's also epidural abscess here. So this is a case of retropharyngeal abscess complicated with epidural abscess. So mode of spread, most commonly, it results from infection from the surrounding spaces that drain to retropharyngeal lymph nodes. So like tonsillitis, pharyngitis, otitis, oral cavity infection. They can also be direct spread from the osteomyelitis of the cervical spine. And if there's penetrating injury and superimposed infection, then they can also be retropharyngeal abscess through that mode. Complications, So intracranial complications can be IJV thrombosis, carotid artery pseudoaneurysm, carotid artery stenosis. As for example, in our case, the infection had spread to the carotid space. In that case, it can lead to carotid artery stenosis, pseudoaneurysm, and then it will lead to stroke, and can also lead to hemorrhage as well, intracranial hemorrhage. Infection, if spreads inferiorly, it can lead to mediastinitis, and we nicely saw the epidural abscess in our case on the MRI. Now the retropharyngeal space extends from the base of the skull to T3 level. Now, it's important to note that there is something which I'm sure you remember from anatomy days. There's a danger space. So I've got a schematic here. So retropharyngeal space here is the one in orange, and the danger space is the one in green, and these two are separated by the ala fascia. So if the infection is deep enough to have eroded through the ala fascia, infection will then go into the danger space, and then it can spread down inferiorly into the mediastinum. So it's very important to image this patient from the base of the skull and up to the chest. This is our second case in the retropharyngeal space. So acute onset neck pain and neck stiffness. Yes, so there is a retropharyngeal effusion. So we don't call it as a collection, there is a retropharyngeal effusion. And also, so we can see it on the sagittal and on the axial sequences. And also, we are seeing calcification at the insertion of the longus colli. So this is a condition called as calcific tendinitis of the longus colli. So what is this condition? There is deposition of the hydroxyapatite crystals within the longus colli insertion. And these patients present with acute onset neck pain, rhinophagia. They can have low-grade fever and elevated CRP. And therefore, an important differential to exclude is retropharyngeal abscess. Here we see fluid in the retropharyngeal space along with calcification at the insertion of longus colli at the level of anterior arch of C2. Now, the degree of calcification can vary. Sometimes you only see a tiny dot of calcification, whereas some people can have profound calcification, as in our case. Now, the way to differentiate this from the retropharyngeal abscess is these patients will not have any rim enhancement, because remember, it's not an abscess. It's just a fluid and reactive fluid because of the HADD deposition. So absence of suppurative lymph nodes. So usually we won't see any surrounding like inflammatory reactions that we see with retropharyngeal abscess. So if these patients will not have any retropharyngeal large suppurative lymph nodes, they will not have any bony destruction. Now, this is the last case. This is a 20-year-old female who presented with acute neck pain. This is a contrast MRI. Again, symmetry is our friend. Okay, so most of you got it right. There is enhancement around the carotid arteries, so at the level of bifurcation, and the enhancement is sort of eccentric. If you see here, it's kind of eccentric enhancement, and in fact, the carotid artery distal to the enhancing part is correct. It's not enhancing. So the patient got better in 2 weeks with antibiotics. So the diagnosis here is yes, carotidynia or typic. So typic is transient perivascular inflammation of the carotid artery. And these patients usually present with pain and tenderness in the region of carotid bifurcation. What we see here is eccentric perivascular inflammation around the carotid bifurcation. This will not compromise the flow typically. And it is important to note that this is a diagnosis of exclusion. So please do not make this diagnosis upfront. This is a diagnosis of exclusion. These patients usually improved on antibiotics after 14 days, either spontaneously or with anti-inflammatories. The important differential here is carotid dissection and vasculitis, and both of these were in fact included in our patient. So this is the CT angiogram of another patient, young female patient, that shows eccentric soft tissue thickening around the left carotid artery. So this was carotidynia. So take-home points. In patient with maxillary sinus opacification, always check the teeth to look for potential odontogenic cause, because then the treatment becomes completely different. Then peritonsillar abscess is different from tonsillitis, and it is different. It is important to make the differentiation between the two because they are managed differently. So peritonsillar abscess has to have surgical drainage, whereas tonsillitis can be managed with antibiotics. Remember to look for intracranial complication of sinusitis, mastoiditis, because they're not always simple sinusitis or mastoiditis. So always have a high index of suspicion, especially if the patients are immunocompromised. So if immunocompromised patient with sinus thickening, look hard for the surrounding soft tissue infiltration. Look into that retroenteral fat. Look at the premaxillary fat pad. Look into the orbits. If there's any infiltration, you have to alert the clinical team instantly. And in a case of retropharyngeal collection, always do contrast scan from the base of the skull to upper chest to look for the potential complication and spread. So there we go. What we discussed today are common infective and inflammatory conditions of the head and neck. We covered the spaces of the head and neck. We learned about their causes, the mode of spread, their presentation, the imaging finding, and of course the complications. Remember, complication is really important in head and neck. It's not about the diagnosis, which sometimes the clinicians can make on their own, even without the imaging. It's the complication that we add value to. Thank you for your attention. And that's my email. If anybody wants to reach out regarding anything, I'll be happy to connect with them. So question-wise, I think they're saying show the case of invasive fungal sinusitis. Anybody wants to add anything before I proceed? Anything else? Dr. Akshay, you want to say something?
Terrific, and of course I love the last slide. So he's New Zealander, right? Or is he Australian?
Yeah, New Zealander. No, it's the common college. So we share everything with New Zealanders, and they are, in fact, our neighbors.
Yeah, absolutely. Oh, this was great. Yeah, I really enjoyed the talk. There are some questions in the Q&A.
Yeah.
If you want, you can just have a look, or if you want, I can just,
Okay.
So Vaishak is asking, in labyrinthitis, the T2 hypo-intense signal appears hyper-intense in flare. That's what he's asking. I'm not sure I got the question.
T2 hyperintense. Yeah, so that's correct. So these are the hyperintensity because there's inflammation. So inflammation is always going to be hyperintense on flare. It is inflammation, so it's the fluid. That's inflamed fluid, which will be high signal on flare, but on the T2, the signal is reduced. And when we do the contrast scan, we will see the enhancing inflammatory tissue. Then we have why use the term preseptal when the septum cannot be seen on imaging. It's more of a from the clinical point of view, because we can't see the septum. In fact, we can see the septum on MRI, but the clinicians can see it when they do the surgery. It's important for them. Should we not use preorbital? So it's a periorbital cellulitis. I'm sure preorbital, if you say, the clinician will understand you, but it is this is the nomenclature that we use, periorbital cellulitis. Maybe one of you can do a paper on it and present it somewhere. How to differentiate between retropharyngeal abscess and the prevertebral abscess. So that's a good one. I think it's very hard. Let me tell you, it's very hard, and even sometimes even I struggle. But the pre-vertebral abscess is, if you do the MRI, it will usually go into the disc spaces as well, and usually from my experience, it will go into the epidural spaces as well. So on CT, we cannot differentiate between the retropharyngeal abscess and whether it has invaded into the preorbital. But also, depending on the extent of infection, sometimes we can just give a clue to them that this is the periorbital. So remember, prevertebral is just it's part of the perivertebral fascia together, which includes the prevertebral. So the perivertebral will include the perivertebral tissue as well. So. As I said, it is really hard on the CT to differentiate between the two, but on MRI we can differentiate. What happens in mumps? So mumps is just a viral infection of the parotids, and what happens in imaging wise is there's just the inflammation and induration of the parotid glands bilaterally. There's no specific finding. It's just when it happens bilaterally, then we can say it is mumps, or it's actually parotitis. And if it happens in children, it's mumps. And then if there's bilateral swelling, we also have to exclude other causes like inflammatory and autoimmune causes, like they can have sarcoidosis, Sjogren can be there. But again, clinically we can always differentiate. So these are usually children, and they will not have other signs, like the biochemistry will be normal as well. So next one is, due to the presence of epidural abscess, is there a possibility that there is a prevertebral abscess more likely? Yeah, I think I would agree with that. So we can say that it's the retropharyngeal abscess that is the parts, and then it can go into the plant. Show the cases of pre-septal cellulitis. Okay, I'll show that. Is there a difference in the management of acute and chronic invasive fungal sinusitis? I think acute has to be managed more aggressively. And depends on where what the complications are. So acute is a potentially life-threatening condition, and it will spread. The spread is more acute in the surrounding soft tissues, so of course it has to be managed aggressively. I've seen they have to sometimes remove the whole eye, enucleation of the entire eye if this infection is spread. So definitely yes. How to differentiate invasive from complicated bacterial sinusitis? So there are some cues. For example, invasive fungal will have the black turbinate sign, is pathognomonic for invasive fungal sinusitis, whereas complicated sinusitis, they can have all the same conditions, but the invasive fungal is also the one that occurs in the immunocompromised. So that history is also important. So immunocompromised diabetic patient, that's when we can give a hint to the clinician that it can be fungal sinusitis, and of course they have to do the biopsy, or they have to grow it in the culture to see what the inciting agent is. But often the invasive fungal is usually you have to, if they're immunocompromised or diabetic patient, then that's there. And these patients can also have hyperdensity on the CT. Then I saw preseptal mean lid is different. So no, the septal. So septum is different. It is separate from the lid. A septum is the fibrous thing. A septum doesn't mean lid, but for us radiologists, we can understand that the preseptal is the swelling restricted to the lid because it hasn't gone deep into the orbits. So just to understand it, you can say that it is the swelling of the lid, but it's actually not, because the septum is not equal to the lid, of course. So I think there's a lot of confusion regarding this septum and the lid. So lid is something. See, as I said, is the septum is the fibrous soft tissue, and it extends from the periosteum. I'll go to that slide and explain to you. So it's typically more common on the left side. I have seen only a handful of cases. And no, I've seen one on the right side as well. So I'm not sure what your experience has been with the left side, but yeah, the two cases that I showed was on the left side, but I have seen a case on the right side as well. Okay, so let's go on to the cellulitis case. See, usually the imaging will be done by the clinician if they are not sure about the whether it's a orbital cellulitis. So the only thing they want from us to differentiate the periorbital cellulitis from the orbital cellulitis. So here we can see this is the septum here seen nicely. And in the case of orbital cellulitis, I agree the case is very subtle. But if you look at the fat here on the infected site, this is the normal side. So this is a normal fat, whereas on this side, the fat is indurated. So there is although we are not seeing this soft tissue that we're seeing with the preseptal cellulitis, there is infiltration of the fat. So that fat is, because that's involved, we can say that this is a case of orbital cellulitis. On this side, this is the septum here, and we can see there's a soft tissue edema is limited anterior to the septum. So this is a case of periorbital cellulitis. So it is somewhere here. And the septum is here. So don't confuse lid with the septum. Here we're seeing the septum nicely. So this is the lid here, and this is the septum. This is the periosteum. Any other?
Hello.
Hello, are there any more questions, Dr. Akshay?
I think you've answered all the questions. Thank you so much for patiently taking the entire talk and answering all the Q&As. Clearly, I mean, we don't realize when we create it, right? But the septum is something which clearly has a lot of confusion associated with it. So I'm so glad that you were able to clarify that also. So thank you so much, Achal, for this lovely session. It's really nice
thank you so much.
to have you back in India, and I'm sure that we will have more sessions from you as well. And wish you all the best in your future endeavors in and around the NCR region. And as I said, if you come to Bombay, do visit Tata Hospital.
Absolutely. Thank you so much. Thanks.
Really glad that this worked out. And thanks to all the